Back to your seats, please. I know everyone's anxious to start their weekend. I'm happy to say that we've had an outstanding group of speakers today, and we've saved, if not the best, and she may well be the best, at least one of the best for last, and that's Liz Bankert. She is the Assistant Provost and Executive Director of the IRB at Dartmouth. She's a past president and a Legacy Award winner for ARENA, the Applied Research Ethics National Association, and a member of the teaching faculty for Primer. She's also served on SACHARP. Liz is speaking today on valid informed consent education using teach-back method in research setting, and I think that's something that's near and dear to all of our hearts. Thank you all for sticking this out. Please give Liz the full time, and I'm sure you'll get something from it. Thank you.
Hi, everyone. Can you hear me? Was that a no? Louder? Closer? Woo, okay. I am so thrilled that you're staying to the bitter end. I thought it was just going to be Phil and I, our great IAV guy. He said he'd listen to me, so. I do, as I understand it, I'm kind of singing to the choir here. I know that many of you are working on improving the consent process, and so I'm really looking forward to getting through my presentation, hoping we have time to discuss, because as far as I can tell, we really are just starting this journey. There's plenty of literature out there that says we need to do something to improve comprehension. I haven't seen as much attempt to do so, and that's why I'm really interested to hearing about what you all are doing. So again, thank you, and I'll just tell you about our journey, if I can. Okay, so way back in 2000, when we were all severely under-resourced in the IRB office, our chairman and I, for every task we were doing in the IRB office, we said, is this really improving the protection of human subjects, or is what we're doing not improving the protection of human subjects? And so, for example, we looked at adverse event reporting. Remember all those years ago when we used to get hundreds of adverse event reports in? And so we did some work and tried to get that changed so that we weren't getting every single adverse event in. Another topic we thought about was at our IRB meetings. I'm sure this doesn't happen at your IRB meetings, but at our IRB meetings, we seem to be spending too much time wordsmithing the consent forms. And so we said to ourselves, you know, is this really important to wordsmith these consent forms? And so we said, well, let's figure it out. So we pulled together a bunch of research nurses, and we said to them, after you've enrolled a patient, turning now into a subject, into a research study, could you hand them a survey? A very simple survey, and they did. So we had OBGYN, cardiology, oncology. It was a small N, somewhere about 100 subjects, just to give us an idea. And we asked about randomization. People weren't really understanding that concept. We asked about why you were enrolling in the research study. People really seemed to understand it was for future patients. But the question we keyed in on was, how did you decide whether or not to enroll? What did you use to decide? And we had options there for them. Investigator, research nurse, consent form, other. Every single person circled consent form. So we knew, okay, the consent form is important. It doesn't tell us whether or not wordsmithing it is important, but it tells us a consent form is important. Almost every single I want to say 85 to 95% of the people circled research nurse, and a couple people circled investigator. So we thought this was interesting. We got all the research nurses back together, and we said, look what we found. You know, it looks like you're kind of key in whether or not people enroll in research. And of course, they said, we know that's our job. That's what we do. We tell people about research studies. So again, this is the IRB talking to a bunch of research nurses, and one of them volunteered to create a video on how to obtain consent in research and how not to obtain consent in research. And so again, this was back in 2000. We said, great, let's do that. And she did. She created this video and sent it to the IRB, and we were hoping to, use it for other research nurses. And the first part of the video, it was very clear. This was not how you want to obtain consent. It was chaotic. There was not a good dialogue. There was not a good, it was very obvious how not to get informed consent. How to get informed consent, it was in a quiet setting. They were sitting next to each other. The research nurse had the consent form. She went through all the elements in the consent form. There was a lot of eye contact. The research nurse said, would you like to enroll in the study? And I'm thinking to myself, wow, she did a really nice job explaining that study. And the patient took the consent form and signed it. Now, because you know what the talk is about, you can probably guess, but it took me, it took me a little while to figure out what was missing from that picture, even watching it, because she did such a nice job. From my perspective, of course, I'm the IRB, I know what the study was about, in describing it. But what was missing from that picture? Everybody? Huh? Anybody think about what's missing from that picture? I can't hear you, but I hope what you're saying is there was no attempt to see what she actually understood. There was no attempt to see if she's thinking about what she's cooking for dinner, or if she's thinking about she's got to go pick up her son at baseball practice, or she's thinking that I was just diagnosed with breast cancer. What am I going to do? There was no attempt to kind of get the mind frame, the comprehension level of the patient. So I said that. So we brought all the research nurses back together, and we said, what can we do? What do you think we want to improve? How can we improve this? And nurses, do we have research nurses here? I love research nurses. They want to do things the right way. And we said to them, how do you think we can help this situation? So we created, again, this is 14 years ago, what we called the ICEFOOT, the Informed Consent Evaluation Feedback Tool. So it was very, very simple. A list of questions that the research nurse handed to the potential subject before the consent process and said, I'm going to go over a lot of information. This is what you're going to need to understand before enrolling in the study. And we just went right down through the elements. You guys are all familiar. The purpose, the benefits, the risk. Does everyone get the same treatment? How is this different than if I didn't enroll in the study? Does research cost me anything? Can I stop? This is all, who will view my medical records? Who do I call if I have a question? And my questions are. So we created very, very simple. As an aside, originally we had yes, no responses, or like multiple choice responses, and we decided to take those away. And we took them away, which I think is a good thing, but I think we took them away for the wrong reason. We took them away because our attorney told us if someone circled the wrong answer, and then we somehow saved this, and then they came back and saw that the person circled the wrong answer. And really, so we took them away, but really, in the long run, it turned out okay, because this was not to be used as a test. This was to be used at enhancing the dialogue. And so we asked this great group of research nurses to use this evaluation, and they did. And I said, okay, let's ask the same questions as we did before. And this time I added the last question was, how helpful was this checklist in helping you make your decision? And again, this is a small number. These are small numbers. This group was even smaller than the 100 because I figure after thinking about it for a little while, it just seemed like common sense. This is not rocket science. Every single person on a scale of 1 to 5 circled 5. This was very helpful for me. And then I had kind of a blank text comment field, and I said, why? And they all said, without prompting, so there wasn't a multiple choice, without prompting, they all said, if you didn't tell me what questions to ask, I wouldn't know what questions to ask. I mean, who would even think that there might be increased risks? You're talking to your physician who is now turned into a researcher. I mean, coming in off the street, would that even cross your mind as a layperson? And it kind of reminded me of around the same time, I was getting a construction loan for this house that my son was going to finish. And I had no idea that it was a 5-year balloon payment. And it was just a complete coincidence that I happened to call the bank at the time to see if maybe I should refinance. And she said, well, yeah, this is a balloon payment. I had no idea. Well, why did I have no idea? I didn't know what questions to ask of those 10 pages of wording that I, as a non-mortgage person, I didn't even know what questions to ask. So I try to remind myself, we're in this world. We've been in it, in my case, for 25 years. We know the lingo. And to come off the street, it's just really hard for us to do. So I always try to remind myself of that. You're coming into a situation where you do not know the language. You don't even know that you should be thinking about the risk-benefit ratio of enrolling. Why would you? So as we all know, we want to improve the process. Medical research is really important. So I'll continue with our journey. Let's see if I did this backwards. So, okay, here's the, oh, I'm going backwards, darn it. Okay. So that was so then what happened, a couple years down the road after this, we have a relationship with a clinic in Tanzania. And, working in Tanzania, are people really understanding the research project? And again, the research nurses said, well, we want to use this because we want to see if people are understanding. And the research, so I gave the research nurses this checklist, and they turned it into this for themselves. They said, so this was to teach each other. Research nurses over there did this all on their own. After reading the patient paragraph of the consent form, ask the patient the following question. If the patient answers correctly, check the box and move on to the next paragraph. If the patient answers incorrectly, explain the answer to the question again, then check the box. So again, this was the research nurses did it themselves. And this is what they created, this very nice with the check boxes. So I bring that to your attention because what we found in working with research coordinators, research staff, is that they really want to improve the process of obtaining informed consent. Most of them had never been formally taught at all before being put in there and asked to enroll patients in a study. So, fast forward to 2012. I, in the meantime, had gone to the provost office at Dartmouth, and I did like a broader compliance. And then our IRB director left, so I went back to the IRB office and happened to be talking to an oncology nurse. And she said, you know, I'm really concerned. I'm not sure my patients understand when they're enrolling in a research study. And I said, well, have you ever heard of IceFoot? And she said, no. So it wasn't something that people were using. Of course, this is now 5, 6 years later. So we decided to pull together a team at Dartmouth, and we're proud of the fact that it is both IRB people and research study team members. And because really the IRB is 1 or 2 steps back, as IRBs know, we tend to focus on the consent form. And they tend, what we're hoping to improve is the actual process. So a bunch of us got together and we said, okay, let's just start from a clean slate. Let's see how we think we can improve the process. So, you know, Joan talked about Henry Beecher this morning. We went back and read work from Henry Beecher. We looked at the Belmont report. We looked at some of the studies that led to the development of the Belmont report. We know that in the Belmont report, one of the first principles is respect for persons, meaning we should obtain informed consent. And we're just kind of acknowledging that, yes, this is still the case. We still want to do this. After the Belmont report, you know, there's still many cases where people did not feel that they were informed all these years later. Joan talked about Jesse Gelsinger. And I did promise Paul Gelsinger that every time I spoke to researchers that I would remind them of Jesse, and that Paul's very, very strongly encourages research. I mean, we could talk about this case for hours, but it really wasn't, he completely trusted the researchers. It wasn't until Paul Gelsinger went to the RAC, the Recombinant DNA Advisory Committee, and which is public, and heard the scientists talk about the study, that he realized this was not ready for prime time. This was not ready for my son. And it was only then, I mean, weeks, months later, that he decided to file suit. I mean, he had trust in the physicians when Jesse died and after Jesse died. So Paul Gelsinger will say, you know, you need to inform us. We want to do research. We just need to do it right, and that's what we all are here to work on. But we have to acknowledge the challenges. You know, consent forms are 40 pages long. They're going to get longer if we start including the alternatives and the risk and benefit of each alternative out there. There's time constraints on PIs. You know, physicians/researchers, wow, there's just not enough hours in the day. There's a persistence of the therapeutic misconception, which we could talk about. There's a literacy issue, health literacy issue in particular, and then there's a lack of training. The research nurses and research coordinators just kept telling us that they really didn't have the training that they thought they should have in obtaining consent. So, and Joan mentioned this earlier, we said to ourselves, again, this is our team getting back together, who are the stakeholders in the research community for whom obtaining consent is important? Who would you guys think of? Can you think of? Who's it important to in the research community? Any? Holler it out there. We all know. It's important for all of us. It's important for the researchers, because you don't want someone to enroll in a study that doesn't understand the study and then halfway through they drop out. The regulators, our friendly auditors, they want to make sure that people understand. The IRB, of course, that's our role, is to protect the rights and welfare of subjects. The IO wants to be sure people are understanding. Your local risk management office, of course, the person enrolling in the study, and the just public in general. So we said to ourselves, okay, and Joan also alluded to this, where does the rubber meet the road? Oh, I used to have stars on this. So there used to be stars where it was the researcher and the individual enrolling in the study. Those are the two people that really have the most impact on whether or not there's an understanding, a good level of comprehension. So we did more literature search. There's people all over the place that are working on this, and here's some of them for those of you that are interested. And I hope we can have a dialogue on all of us working together. This is not rocket science. We didn't make up this concept of teach back. The teach back is out there in many, many settings, but it had not yet been brought to the research setting in a broad way. So we looked at what was out there. We kind of focused in on this teach back concept. We looked at the FDA guidance, because we thought, well, if we're going to try and develop a program, an education program, how are we going to get PIs and researchers to come to the education program? And, we found FDA guidance that when tasks are delegated by an investigator, the investigator, of course, has a primary responsibility. The investigator has to provide adequate supervision to those of whom the tasks are delegated. So when the FDA went out and did some audits, this is what they focused on, whether or not the study staff received adequate training. And during the inspections, tasks that had been inappropriately delegated include the following, and at the very end, obtaining informed consent. So, we kind of thought this was good. We're going to go out and talk to researchers. We're primarily focused in the clinical trial phase 1, 2, and 3 world. We're not really focusing on this, although it wouldn't hurt, for minimal risk research. And we just had a great conversation on online research. Obviously, this is not going to be a good fit. But for phase 1, 2, 3 clinical trial research, we're hoping that this program's going to have some benefit. So again, we're doing all this literature search. We're thinking about it. We know the ethical rationale. We focused in on this teach back, and we said, okay, well, this teach back sounds great, and I'm going to talk a lot more about it. But who's going to teach it? Can we even teach it? So we said brought together the research nurses and the research coordinators again, and we said, could you guys help us in this pilot project? We are going to videotape you doing simulated consent, just the way you normally would do it. We're going to put you through this education program focused on teach back, and then we're going to videotape you again. I have to say, very interesting, and they were all for it. We were afraid they were going to be a little nervous about being videotaped. They were just so excited that someone was paying attention to them and acknowledging that the work they do is really, really difficult, that they definitely were on board with seeing what they could do with helping. So we videotaped them doing a simulated consent, which was very, very interesting. A lot of variation in how the consent process was happening. One thing in particular I noticed was, now these tended to be research coordinators, not research nurses. Do we have research coordinators in here? I'm not sure why. I need to do a little more discussion on this. At our place, anyway, the research coordinators regularly said, I'm not discussing the risks with you, the PI will. So the research coordinator left the risks out of the conversation completely. And I don't know if she knew the PI was going to talk about the risks, if that was an understanding. But anyway, that was something I found kind of interesting. Anyway, what happened was we went through this education program and did the video again a week later and then 3 months later, and we were really pleased because we were able to at least teach the teach-back method. Now, this is not to say we increase patient comprehension. That's what we have to do next to see if this really impacts patient comprehension. But the more I learn about it, the more I find that the teach-back is used in other settings. I don't think it's going to be difficult to go down that road. So what I want to do is tell you a little bit about the program. And we call it VOICE, we used to call it VICE, Valid Informed Consent Education, and we didn't like that title, so we threw in the O and the optimized, which is a crazy word. So now we've changed it again, and it's VOICE with a little O. So it's Valid Informed Consent Education Program again. And so what the education program consists of is we go through a background, and I'm going to show you some of what we talk about. A significant focus is on health literacy. And then we teach them about teach-back. And then we have a QI and a demo. And did anybody go through this at University of Kentucky when I was there last? Oh, you did? Okay, well, I've done this at a few institutions. Mostly what we've done is just this 1-hour explanation of the program we're creating, but at a few places I've actually done the 2 sections, the 1 hour of this is what we're doing, and then the second hour is working closely with the research staff to actually teach them how to do it. The reason we add that second hour is because in our pilot program, and what we've learned since is it's not easy to use the teach-back questions. We are all so used to having yes-no questions. We're all used to saying, do you understand? And even put a nod of our head in there with it, and having the other person say yes. And then it's like, phew, and then we can go on. So what our pilot project showed is you literally have to practice with these questions that I'm going to show you in order to really get in the loop of it. But once you do, it becomes more natural. The other thing our research nurses, their concern was that it was going to take much longer to go through the consent process. And actually, after they got the hang of it, whether or not the length increased didn't matter to them because they felt so much more relief knowing that the patient understood step by step as they went through the consent. So we talk about the elements of consent, and for new research coordinators, we explain to them, one of the reasons consent forms are so long is because the regulations require all this information be in the consent form. And some of the research coordinators, new ones, don't even realize that consent form template comes right out of the regulations. So we go through this, we explain that's why the consent form template looks the way it does. We talk about the additional elements. And again, we acknowledge that this is very difficult, all this information that the person needs to understand. As another aside, there are people doing a lot of research on what of these elements really are the most important to the patient versus these elements that were created by administrators in the regs. Laura Beskow at Duke is doing a lot of research on this, meaning, do people really want to understand the purpose, or are they really more interested in what it means to me? Do I have to come into the clinic 3 more times versus 1 more time? What are the really key elements, and at what level does the person really need to understand is what there's research is in that arena. Now, from my perspective, it's going to be hard to give guidance because each study is so different. So what we do in our program, and I think I've got some slides on this, is we ask the research team, you guys need to think about what it is about this research that you think patients should understand. And honestly, maybe someday down the road, that is what the dialogue between the IRBs and the research team will focus on, rather than just this consent form. Okay, so we go through the elements, and then we talk about health literacy. This is just amazing to us. I don't know why, but the information you can find about health literacy is just endless, and basically literacy is at quite a difficult level in the United States right now. Health literacy is even in a more difficult place. And I don't really know why it came as such a surprise to me. Same thing with that mortgage example. When my sister was diagnosed with breast cancer 2 years ago, call her up, tell me what they said. She could remember nothing. And her husband I said, well, you need to get your, Scott to go with you. He's a nurse. I would ask the 2 of them. Neither of them were really able to explain to me what was going to happen. It's just stunning to me. 2 highly educated individuals faced with a life-threatening, disease impacting their family. It was just incredible. They did not understand what was happening. Now, she was not asked to be in a research study, although I think I asked her that, and I think she said she didn't know. So it just reminds us, those of us that are not in the field every single day, it's just not something people think about. So in our program, we go through these slides, and we explain the risk factors. I actually work with health literacy experts to help us on these slides. This slide, we say, who in this picture is not literate? Someone always says the baby. But the point is, you can't tell. You can't tell by looking at the outside. And common misconceptions we talk about: people who are well-spoken and well-dressed are literate? Nope. People will tell you if they cannot read or understand you. No. These slides are in a different order from what I usually do because I'm working with a teammate of mine. But start talking to family and friends. Every time I talk to people about not even just health literacy, but literacy, I will hear a story where my friend's brother, they went up through the same school system. He graduated from high school, has his own grocery store. He's functionally illiterate. He has been able to figure out how to get things done without being able to read. I think his reading level is 3rd grade. And she did not know for years and years and years. They're able to hide it by doing many other, because it doesn't mean you're dumb that you can't read. It means that you haven't been able to read. And Jeremy will tell the story that when he, and I don't know if this is true, Jeremy, I think it was when he was in Tanzania, he would always hand the consent form to individuals upside down to see if the first thing they did was turn it right side up. Now, after learning more about how people are able to, I think most people can figure out if the words are upside down or not, but it was one of the tricks that he said he started as a young physician. So the definition of health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Again, this is all part of our program that we go through. Includes a variety of skills beyond reading and writing, such as numeracy, listening, and speaking. And it also relies on cultural and conceptual knowledge. So the reality is people hide their limited reading skills or lack of understanding with a variety of coping techniques. The healthcare environment can make it difficult for patients to tell us they don't read well or do not understand. And research shows that patients remember and understand less than half of what their clinician explains to them. And again, that is not in the research setting, that's in the clinical setting. So I've already mentioned this, well-educated people may become functionally health illiterate when in pain or confronted with a serious disease or a new diagnosis. And again, this is part of the program, this is what we go through because we're working with people that actually interact face-to-face with the patients. So there's a challenge. Low literacy is associated with poor comprehension of consent materials. Few healthcare professionals, again, have the training in working with people with limited literacy. So what do we do? Well, what I want to do is show you a video, and Phil told me I just had to do this.
I was sick a lot. I was sick a lot because I probably missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them, and I didn't want anyone to know I couldn't read.
I can't read this. Well, I guess doctor gave it to me, so it's okay for me to take it.
When your children have fever, what do you usually give them?
Motrin or Tylenol. Normally Motrin because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4, okay.
I would give her the 4 to 5, a tablespoon and a half.
One capsule.
And it's teaspoon. That's right, 1 capsule.
1 capsule. I don't know what this is.
Twice?
Twice daily.
Okay. So how would you take this?
When I see it's not on there telling you how to take it. It says take it twice daily, but it don't say what time to take it.
Do you know what hypertension means, if I asked you what that was? Because when I look at this, I think, well, maybe you have hypertension, and I've been taking care of that for a long time.
Hypered? Hypered?
Like you're hyper? What does being hyper mean to you?
That's where you can't be still. You always got to be doing something.
Do you think I think you're hyper and have hypertension?
I don't know. That's what I consider it.
Okay.
It being, you know.
Okay. But you know you have high blood pressure. Okay. But hypertension doesn't mean the same to you. So if I ask you if you have hypertension, you're going to just think I think you're jumping around on the chair or something like that. Something different.
Just being hypered, you know.
Okay. All right. Well, I haven't done a very good job teaching you what hypertension is, because I think you take that medicine for your hypertension, and that's one of the things that I try to work with you on is your blood pressure. And high blood pressure and hypertension, to us, is the same thing.
The same thing.
Yeah.
I have a small breakfast, and then I take my pills. I usually take 16 every morning. Sometimes it's difficult for me to take these pills because if they say 1 tablet twice daily, I don't know if they're talking take one in the morning, one in the evening, or take one in the afternoon or one in the evening. So usually what I do is take 2 of them in the morning. Then this way I know I have them.
If you have a reading problem, you go to the doctor. That can be very scary. It's like a nightmare. You walk in that office, and most people, if you realize the first thing you're going to have to do if that's your first visit is fill out a form. Your heart beats real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign. Never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it?
Okay. So, that video, there's so much of this video on YouTube, on these videos, and I think there's a video of a physician from Cincinnati Children's doing this, and I need to, talking about Teach Back, and I need to find that, and I'll talk to Jerry about that. So again, the notion that people are not understanding this information that we're trying to get across, and that we need to spend more time in the research environment, they're not even understand in the regular clinical environment. And we talk about plain language. We go through, everybody knows when you look at a consent form, the wording is, I remember our research nurse said she went with her mother to a doctor's appointment, and the doctor kept saying ambulatory, ambulatory. And after they went out and they were walking down the hall and going, for lunch, the mom said she had no idea what ambulatory meant. And why did the doctor keep using the word ambulatory? So I'm going to catch up because we're already running short on time. We do also, in our little program that we put together, we do talk about the consent form. Because as you remember from the very beginning, consent form is important. We're thinking that at some point it might be more of a reference rather than, if the IRB could think of it as a reference guide, and that they should have more information on the consent process, that might improve things. And then we talk about the actual consent process, and for those of you that obtain consent, this is nothing new. It's just to verify what individuals we hope are out there doing. It should be in a private, quiet, comfortable setting, obviously before the research starts, and throughout the course of participation. This is another angle that we haven't focused on very much. And Gigi McMillan is just a wonderful, articulate speaker who has spoken for Primer many, many times, and she'll speak about the fact that when her son was diagnosed with brain tumor as a young age, her husband could barely speak during the conversation, and what she had wished, now he's fine, he's grown up, what she had wished is that they had gone over it again a couple weeks later, or throughout the treatment. And so her focus is the initial consent process really is just the initial consent process, and there needs to be continuation throughout, which again, I've been with the IRB for 25 years. I don't think we've ever asked that. The other thing before I forget that I want to mention is the new FDA guidance. Have you all seen this? July 2014. New FDA guidance to IRB sponsors and investigators. So I'm just now getting through this, but what I find most interesting so far is that there seems to be more of a focus on the process rather than the form, A. And B, what I find very interesting, and again, I'm just getting through it, there seems to be more of a focus on making sure patients understand the distinction between what would happen to them if they're not in the research study versus if they are in the research study. Which, does that mean that has to double, triple the length of the consent form? I don't know, but that seems to be in this guidance. So take a close look at it. Came out July 2014. We have 60 days to respond. So that time is coming up soon. So again, going through what we talk about in this education program. And the reason I'm going through this with you is because my dream is that you'll all go back to your institutions and do something similar that we've created. We will give you all our materials. If you want to start a program at your institution, working with your research staff, I want to encourage it. Okay, so what is Teach Back? Teach Back does kind of what that IceFoot did. It creates an opportunity for dialogue. The provider gives information, then asks the potential subject to explain it back to them in their own words, and they confirm their understanding before adding new information. Again, not rocket science. Again, we're trying to move this into the research setting. It has been used in the clinical setting with good results. This woman, Claudette Dalton, implemented this teach back process by everyone on the team of surgeons, anesthesiologists, and greatly reduced the cancellation rate of appointments. What they found was when people were supposed to come in for their surgery, they weren't doing what they were supposed to be doing the day before, so everyone canceled. So they started this whole calling people the day before, which I know we all work on, but this is all part of the teach back process. AHRQ has a lot of information on their website and describes it as a widely recommended practice. And what I want to do is, so I've said this several times, it's a way to confirm that you have explained what the patient needs to know. What we found in our pilot, it completely turns the tables from being the responsibility of the patient to understand to being the responsibility of the researcher to explain it correctly. Complete change in mindset. And it's not a test of the patient. It's a test of how well you explain the research study. It should be used with every patient, never assume literacy. And I'm going through this quickly because I just want to show you some examples. Okay, so you don't ask questions. I've already mentioned this. Do you understand? Patients will say yes. Ask open-ended questions. And one of my favorite is, you know, I want to be sure I didn't leave anything out that I should have told you. Tell me what you are to do so I can be sure what is important. I want to be sure I did a good job explaining the research study. When you go home and your sister asks you what the doctor said, how are you going to explain it to your sister or your granddaughter? So it's questions like that that we got the research nurses, research coordinators involved with working on. And honestly, what I've most recently done, because wow, we've had some really complicated consent forms come across our desks recently. I mean, so complicated that I didn't even know where to start on simplifying them. So instead, I've started creating this one-page summary sheet that has, this is what the study is about. And between using a one-page summary sheet and the teach-back method, when you go through the consent form, I'm hoping that we can improve comprehension. We've gone over a lot of information. In your own words, please review what we talked about in this section. Now, I have to say, when we first started this, the ICEFOOT all those years ago, our IRB chair, as I say, was very involved in this, and he used it after explaining, during explanation of one of his complicated radiation oncology studies, went through the ICEFOOT, and at the end, he said, well, you know, tell me what the purpose of the study is. And without skipping a beat, the patient said, to get me better. So this is not the end all. We still have a lot of work to do. But it gave him, and he said he was deflated because he thought he had done a really good job of explaining the study, but at least he realized that he needed to improve how he was explaining the research. So you have all these materials in your packet. Oh, are we going till 4:30? Okay. So when we go, so I'll slow down a little bit here, because what we're actually working on, again, is what are the most important elements. So what we do in our workshop portion of the program is you actually bring the consent form in with you that you're using, and we go through it together, and we embed teach-back questions throughout the master, we call it the master consent form, so that when you're using the consent form, you know, there'll be a big red sentence that says, okay, now ask, and then we'll insert a teach-back question. And then what we do is we have them actually double up and use the teach-back with each other. The other important thing an oncology nurse said she starts her discussion with is to ask the subject, the potential subject, what they know about the research. So then, you know, if that's the very first question, she knows kind of the level of understanding right from the get-go. You know, this is not about being patronizing and dumbing down this information. It's about really assessing how well the patient's understanding. And we also, this is very interesting. I was actually doing an undergraduate class at Dartmouth. I forget what the topic was, but the professor said to me, hey, you know, I use this method in my class, and the kids know it. They know that at any time during the class, I might pick on them and ask them to say something about what we're talking about. And I said, wow, that sounds a lot like teach back, and you're telling them up front. So what if I had told you all that I have a list of your names here, and that at any moment I might be calling your name? Are you going to maybe be paying a little more attention? Maybe. So that's the idea, is to tell the patients in advance, and it's kind of what we did with that ICEFOOT. Tell them in advance, you know, we're going to go over a lot of information. These are the things you really are going to need to understand by the end of this conversation. You know, don't try and trick them towards the end. Again, here's some more teach-back questions that we recommend. And then again in the program, we create a master consent. Here's some examples. The before we go any further, could you explain back to me the purpose of the study? So that's right, right at the beginning of and what it does, hopefully, is open up the dialogue. There's no longer a monologue happening. Right from the get-go, the patient will feel hopefully comfortable that they are going to be part of the conversation. And when it's a complicated study, you slow it down. Tell me when it is that you're going to be coming into the clinic, and so on. So this is kind of an explanation of a summary of the whole program. There's a lot about TeachBack on the web. I encourage you to go in there and look at it. And I'm just going to go through this. We have a demonstration with an oncology nurse that we go through. And then we actually practice it, and then we have a discussion and wrap up. And so I thank you for your time and spending your afternoon, your whole day with us, and this last hour in the afternoon. I, again, really look forward to working with your groups that are also working on TeachBack. So I thank you for your attention.
Questions for Liz?
Is Liz? She's not here. Actually, when I was at Kentucky, after I gave the first part, someone came down the aisle, and I think he said he was a psychologist, and said that he does marriage counseling, and he uses the TeachBack in the marriage counseling. And then at another presentation I gave at Cedars-Sinai in California, a pharmacist came up and said before they release the drug from the pharmacy, they're using the TeachBack method. So I have seen it trickled out there and just encourage its use. Thank you. Yeah?
Yes, I have a question. Jay Parker from NIOSH in Pittsburgh. I really enjoyed your study. I think that it's definitely a very important thing that we need to add. But at one point I noticed that in one of those protocols it said that you ask the potential subject whether they understand, to explain it back. And if they can't explain it back, it said, explain it again and then check the box. So I didn't really understand that. It seemed to be defeating the whole purpose of what you're trying to do.
Yeah, that was a depiction of how the nurses in Tanzania were training themselves and to not check that box until the person had understood. I just found it very interesting that they turned our kind of list of questions into that checkbox. That's how they taught themselves how to use it, actually.
So let's say this happens, in the U.S., and is that going to be grounds for eliminating that subject? Is that what you would do if they can't explain it back? You would eliminate the subject as a potential
Well, so this
subject?
is what the research is going. This is the most difficult part to figure out. You want people to understand the purpose and the risks. At what level? At what level of detail do we want people to understand? Do we want them to understand, we're trying to learn more about drug XYZ. It's not FDA approved. We don't know if it's going to help you or not. It might make you feel less nauseous. It might not. Is that enough? Or do we want them to know way more than that? That's the very difficult part of this whole thing.
Yeah, I don't think we can expect them to recite back everything that they were told. Right, okay.
Yeah.
But as long as they remember, most of it or a good piece of it, then that's considered okay.
But this is exactly what the research nurses have told us. They in the pilot project, two things. Either people don't want to hear about it, and they just want to sign up. They don't want to even listen to it. And they say, well, should we allow them to sign up? And we'll say no, tell them, you need to go through. And then, or how much do they really have to know? And again, that is the most difficult part. Yeah. But right now, from what I understand, there's just no dialogue, very little dialogue going on. So this is our one little baby step to at least get a dialogue going.
Right. Thank you very much.
Thank you. Oh, Joan's going to have her.
Liz, thank you for a terrific talk, but mostly thanks for the extraordinary work I think you've really set, and those who've also been working on the teach-back method are setting very high new bar for all of us, or all of you working in the field. So I have a question about a slightly different meaning or dimension of the teach-back. How do you teach back to the PIs and sponsors about the problems that you uncover vis-a-vis the content and quality of the consents? For example, we all know about the 10 to 20 to maybe longer, as you alluded, often industry-sponsored consents that in multi-center trials, they're dense, they use a lot of scientific terms, they're often cut and paste jobs, and quite often institutions and freestanding IRBs, hospitals, universities are reluctant to start to tinker with them because it certainly lengthens the process, which in and of itself shouldn't be a deterrent. But there just isn't an easy way to get farm sponsors and industry sponsors to change their SOPs vis-a-vis consent. Similarly, there are many investigators who are still writing or computer-generating consents that are not adequate. How do you take all of this amazing data and give it back to the sponsors, give it back to the investigators at your institution, or again, wherever they are in the multi-site trials, so that you'll start to have better consents going forward?
Yeah. Well, at 2 primers ago, when we were in San Diego, there's always consent workshops. And there's usually a consent workshop where people are complaining about the terrible long consent forms. But I went to the workshop that was conducted by industry. And what do they complain about? IRBs wordsmithing the consent forms. So I spoke to them afterwards, and I said, if the consent forms were decent in the first place, maybe we wouldn't wordsmith. And they're like, no, it doesn't matter. You're going to wordsmith no matter what. So on my list of things to do, and I think it's very important, is to talk to industry. And until I do that, I've almost given up on the consent form, and that's why I'm focusing on the process and developing my own summary sheet, and then this teach back, because that is such a huge hurdle that it's going to take a whole nother set of energy. But I think what it is, when I talk to these people from industry, they said if there's anything they could do to reduce the wordsmithing of IRBs, because if there's 20 IRBs wordsmithing, then the question becomes, well, does IRB 1 know what IRB 4 changed in the consent form? And then you've got 20 different versions of the consent form out there. That's not necessarily the best way to go either. And they don't tell us what the different sites did with the consent form. So it's a huge hurdle. These women seemed very interested in having a conversation about it, but I have not pursued since that primer session.
Well, actually, that really underscores your slide about the fact that the signature or a signature on a consent is certainly not evidence that there was valid binding informed consent. My only other very quick comment is about your slide, which of these people is illiterate. I would submit that we're all scientifically illiterate in the face of most consent forms, as evidenced by your illustration of the balloon mortgage. So thank you again, Liz.
Thank you.
Thank you very much. I just wanted to quickly thank Jeremy, David, Joan, Carol, Simon, and Liz again for the wonderful day that we all had. Thank you for all of you for coming and spending the day with us in Northern Kentucky. And I look forward to seeing everybody next year. For those of you for CME credits and course evaluations, please look out for the email that will be coming from the CME folks. Everybody have a good afternoon, enjoy the weekend, and have safe travels home. Thank you. Yeah. Good to see you, and thank you.
Just a city boy.